Hello everybody and welcome back to my channel. Today we're going to be talking about ARDS, which stands for Acute Respiratory Distress Syndrome. So let's start by first defining what this entity is, right? So definition is basically you're going to have respiratory dysfunction within 1 week of an insult, right? And this can be anything. It can be sepsis, it can be shock, or it can be septic shock, it can be smoke inhalation, it can be pancreatitis, it can be transfusion associated lung injury, TRALI, right? It can be any number of it can even be from burns, because that can also cause shock like situation. So these are all the conditions that can predispose to, and within 1 week of something like this, if you start having respiratory dysfunction, that would be your ARDS. And another thing you want to remember here is that they're going to have severe hypoxemia, right, wherein your PaO2 is less than 60 mmHg, for instance. Okay, and radiologically you're going to have bilateral opacities and patchy lesions on chest x-ray. Okay, so that's going to be ARDS. Now the pathology here is like this: you have an insult, and that sort of attracts inflammatory cells which release cytokines, and these cytokines sort of like increase the vascular permeability of your alveoli, and then there is like an inrush of protein rich fluids that causes washout of your surfactant, and when there's no surfactant, it's not able to prop the alveoli open, and then they undergo atelectasis, right? So that's going to be your pathology here. Now when your alveoli have undergone atelectasis, but your capillaries and your perfusion is normal, this condition is called an intrapulmonary shunt. Okay, and another important thing that I have to mention here is that it has to be a non-cardiogenic cause, right? This insult has to be non-cardiogenic, like you have to exclude any cardiac abnormalities. Like let's say you look at the jugular venous pressure, you look at pedal edema, so basically, and you do a TTE, for instance, right? So your pressure is normal, there's no pedal edema, and your TTE shows like normal morphology and normal motion of all the valves and the heart valves and everything, right? So you want to exclude. This is a non-cardiogenic cause of a respiratory dysfunction. That's ARDS, right? So how do you go about diagnosing? How does a patient with ARDS present, right? First, you're going to have tachypnea, breathlessness, tachycardia, chest pain, confusion because of the hypoxemia, right? They're going to have, because of the tachypnea, they can have respiratory alkalosis. In fact, if a person with ARDS develops respiratory alkalosis, if they develop respiratory acidosis, it is a sign of impending respiratory failure, right? Impending failure. So you want to be, they want to be having respiratory alkalosis because they're trying to compensate, right? So, and upon auscultation, they're going to have diffuse crackles, diffuse crackles, right? So when you do a bedside USG, you're going to see that there is decreased lung sliding. There is evidence of atelectasis. If you do an CXR, you're going to see bilateral opacities and lesions, right? CT can be considered, but usually USG and the CXR and the presentation itself and the predisposing factors are enough to make a diagnosis of ARDS. So how do we manage ARDS? So before I touch upon the airway management, I will finish off the other things so that we can talk about the mechanical ventilation of an ARDS patient, right? So first things first, you want to give them IV fluids, right? It has to be a balanced crystalloid like Ringer's lactate, okay? And you want to give them adequate nutritional support because there is a lot of catabolism with ARDS, so you want to offset the catabolism, right? And if it is a steroid sensitive predisposing factor that led to the ARDS, you can give them steroids, either methylprednisolone or dexamethasone, right? Now coming to mechanical ventilation of a patient with ARDS, first of all, your target PaO2 is around, your target PaO2 is between 60 and 90 mmHg. You're keeping it here because you want to prevent oxygen toxicity. An important thing is we do something called low tidal volume ventilation, right? Now this means basically you're keeping the tidal volume somewhere around 420 or lesser because you want to prevent barotrauma to an already damaged lung, you know. And the way that you find out whether you're adhering to the low tidal volume ventilation is that another concept that comes in here is permissive hypercapnia, right? Going to be a little bit more than CO2 is going to be a little bit on a higher tolerance, right? And that's how you know that you're adhering to LTVV, right? One of the things that I should have probably mentioned before is that there's this PaO2 by FiO2 ratio. Basically, this is your the PaO2 and the FiO2 setting on your ventilator machine will give you, this is expressed in mmHg and this is expressed in percentage, and the ratio of this, if it is less than 300 or equal to 300, that's how you that's one of the things that tells you that it is an ARDS. And your PEEP, which is your positive and expiratory pressure, this is kept at around 13 mmHg, 13 centimeter of water. So this is a kind of a higher PEEP. The PEEP is what keeps the alveoli open, but then the tidal volume is kept a little bit on the lower side and PEEP is kept a little bit on the higher side. This is the concept behind mechanically ventilating an ARDS patient. Another thing I want to say is that you can have an arterial line inserted for these patients for blood pressure monitoring, right? And a central venous line for administering vasopressors, because there is a very high chance that they might have some amount of hemodynamic instability, especially because of whatever was the predisposing, like especially if it was shock that caused your ARDS, then you want to have a central line in place for uh, administering vasopressors and stuff like that. Now, one more important concept that we want to touch upon is prone positioning. Prone positioning. So, this is supposed to be quite helpful in the case of ARDS, because the posterior lung lobes have a lot of alveoli. So what you're going to do is, if you put them prone, you're sort of able to recruit them a little bit more, and it sort of decreases the intrapulmonary shunt, and it increases the functional residual capacity, and it decreases mortality. It is shown to have a mortality benefit. Like, prone positioning is shown to have a mortality benefit in ARDS. So this is one of the things that you can consider when ventilating a patient with ARDS. So that is about it for I hope you all got like a nice overview of how we ventilate a patient and how we manage a patient with ARDS, what caused it in the first place, the pathology behind ARDS, and then how we went about diagnosing it and how it presented, and then how we manage it, right? Both the supportive concepts and the ventilation concepts, which are all explained in this video. I hope you found this helpful. Pretty high yield, especially for step 2 and step 3. And very high yield if you're working in an ICU setting. Definitely go through this in much more detail, rewatch this video if you have to, and let me know in the comment section below if there are other videos that you want me to make, specific topics that you'd like me to cover. Thank you so much for listening. I will see you next time. Good luck.